Welcome to the ASCO eLearning Weekly Podcast, a weekly educational series focused on helping learners identify knowledge gaps and stay up to date with the latest in new drug developments, cancer treatments, and patient care approaches. This episode is complimentary to an education session presented at the 2019 annual meeting. For more detailed information about the education session, make sure to check the episode description for links to ASCO's meeting library.
Hi, my name is Dr. Stephen Liu, Associate Professor of Medicine at Georgetown University and Director of Developmental Therapeutics at the Lombardi Comprehensive Cancer Center. Today, we compare two cases that relate to the management of patients with acquired resistance to EGFR tyrosine kinase inhibitors. These two cases have similarities, yet the recommended management may be different. Let's take a look at the cases. Patient case 1 is a 48-year-old female never smoker diagnosed with metastatic adenocarcinoma of the lung. Initial molecular testing identified a sensitizing EGFR mutation, specifically an exon 19 deletion. She began first-line therapy with the first-generation EGFR kinase inhibitor erlotinib and achieved a rapid response to therapy. After 11 months, surveillance imaging identified progression, with growth of multiple lung nodules and a new liver metastasis. She has no new symptoms, but is understandably anxious about the next steps in her management. Of note, PD-L1 expression from her original biopsy was 90%. Patient case 2 is a 52-year-old female never smoker, also diagnosed with metastatic adenocarcinoma of the lung. And as in case 1, initial testing identified a sensitizing EGFR mutation, this time the L858R point mutation in exon 21. She began first-line therapy, but with the third-generation kinase inhibitor osimertinib. She achieved a response to therapy that persisted for 19 months, when imaging revealed progression with growth of multiple lung nodules and several new bone metastases. PD-L1 expression from her original biopsy, 10%. As you can see, both cases are similar, but there are some differences. What is the standard recommended management? Would you recommend a biopsy for further molecular testing, platinum-based chemotherapy, immunotherapy with a PD-1 or PD-L1 inhibitor, or a combination of chemotherapy with immunotherapy? Are your recommendations different for these two patients? And if so, why? These two cases highlight an ongoing challenge in our clinics, acquired resistance. Both patients were diagnosed with metastatic non-small cell lung cancer, harboring a sensitizing mutation in EGFR. The two most common sensitizing mutations are deletions in exon 19 and the exon 21 L858R substitution. While there are differences between these two mutations, their clinical management is the same. There are now 5 TKIs approved as initial therapy in this setting. The first-generation inhibitors gefitinib and erlotinib, second-generation inhibitors afatinib and dacomitinib, and the third-generation inhibitor osimertinib. All of these agents are reasonable first-line options and would be preferred to chemotherapy or immunotherapy. The most compelling results come from the randomized Phase 3 FLORA trial, published by Jean-Charles Soria in the New England Journal of Medicine in 2018. In this trial, osimertinib was compared not to chemotherapy, but to the first-generation EGFR inhibitors gefitinib or erlotinib. Osimertinib was associated with a superior progression-free survival, with a median of 18.9 months compared to 10.2 months with a first-generation inhibitor, for a hazard ratio of 0.46, which was highly statistically significant. While the 5 approved EGFR TKIs have many similarities, one important difference is the expected mechanism of resistance. For the first and second generation inhibitors, the majority of acquired resistance will be mediated by a secondary mutation in exon 20, T790M, where threonine is substituted with methionine at position 790. This mutation alters the mutant EGFR receptor, reducing the efficacy of first and second generation inhibitors. The third generation inhibitor osimertinib retains activity in the presence of T790M. While it is now the preferred first-line therapy, it was initially approved for patients who had progressed on a prior TKI if that resistance was mediated by T790M. As a result, it would be standard for patients progressing on an early generation EGFR TKI to undergo molecular testing through a tissue biopsy or through plasma testing, also known as a liquid biopsy, to search for the presence of T790M. In an analysis published by Jeff Oxnard in the Journal of Clinical Oncology in 2016, patients with T790M detected in plasma had similar outcomes to those where T790M was detected by tissue, though there is a notable false negative rate with plasma. A negative plasma result should be followed by tissue testing when possible. If T790M were detected in either tissue or plasma, the use of osimertinib would be appropriate. For those patients who progress on first-line osimertinib, the mechanisms of resistance remain unclear and are under investigation. Recent work has shown significant heterogeneity, including amplification of MET and the emergence of gene fusions in RET or BRAF. While biopsies here can be informative and are the subject of innovative clinical trials, a biopsy in this setting would not be considered standard. Note that both patients had biopsies showing PD-L1 expression, 90% in case 1, 10% in case 2. This information is not relevant to patient management. For patients with high PD-L1 expression, use of first-line pembrolizumab was superior to chemotherapy in the KEYNOTE-024 study. This study, however, excluded patients with EGFR mutations, as did the KEYNOTE-189 study of carboplatin, pemetrexed, and pembrolizumab. The Empower 150 study did include patients with EGFR mutations, but only after they had received appropriate TKI therapy. This trial explored the combination of carboplatin, paclitaxel, bevacizumab, and the PD-L1 inhibitor atezolizumab, published by Mark Sosinski in the New England Journal of Medicine in 2018. In an exploratory analysis of patients with EGFR mutations, there was a benefit from adding atezolizumab to carboplatin, paclitaxel, and bevacizumab, but this was not the primary endpoint, and the optimal management of patients in this setting remains unclear. Let's return to our two patients. Case 1, 48-year-old female, EGFR exon 19 deletion, progressed after 11 months of erlotinib, PD-L1 90%. Case 2, 52-year-old female, EGFR exon 21, L858R, progressed after 19 months of osimertinib, PD-L1 10%. In both cases, patients were found to have a sensitizing EGFR mutation and were treated with an approved EGFR TKI, achieving a high quality and rapid response. Both patients now have progression of their cancer. The patients had different sensitizing EGFR mutations and differences in PD-L1 expression. But here, the only relevant difference is that patient 1 had received the first-generation TKI erlotinib, and patient 2 had received the third-generation TKI osimertinib. For progression on a first or second-generation EGFR TKI, the standard recommendation is to test for the presence of T790M, either by plasma or tissue or both. If T790M is detected by either method, osimertinib is the recommended therapy. For progression on a third-generation EGFR TKI, osimertinib, biopsy is not yet considered standard. Appropriate options here are chemotherapy alone, with consideration to the combination of carboplatin, paclitaxel, bevacizumab, and atezolizumab. Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. For more information on the treatment of advanced lung cancer, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive eLearning Center at elearning.asco.org.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org. The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.